Good afternoon, young ophthalmologists, and good afternoon, Dr. Ubong and Dr. Fashina. We are happy to have you with us today. We're looking forward to a stimulating session with both of you. Oculoplastics is one of those areas where the young resident starts picking up skills earlier than anterior segment. I would think that before or maybe after pterygium excision, evisceration is the next thing a junior resident will learn. And seeing as this is the case, it's very important that at least the pre-part 1 resident gets a sound idea of how to carry out a proper evisceration and the use of implants. Exenteration is another matter entirely. It's a little bit more complex than evisceration, but it's also one of those things that the general resident would do probably before doing maybe a cataract surgery or even a more complex ophthalmic procedure. And so in continuing of our oculoplastic series, this is the second in the series. The first one we had principles of eyelid repair, which was a very, very rich presentation. And then this is the second one on principles of evisceration, exenteration, and use of orbital implants. We have quite a number of us already, so we'll be starting. Before we start, I want to thank everyone for joining us again. And please, if you can, join us quickly. At the seminar was oversubscribed, so there is a YouTube link which is streaming presently alongside the Zoom presentation. If you can't join us here, please tell our friends to join us on YouTube. Questions on YouTube will also be monitored. And if you have questions, please drop them in the chat box. It will be monitored also. We will keep questions till the end of the presentations, and then Drs. Ubong and Dr. Fashino will take them together. To take our second oculoplastic series webinar today, we have Dr. Ubong Akang. I hope I'm pronouncing the name properly. He's of the National Eye Center, Kaduna, the content special grade 1 in the oculoplasty and orbit department. He is an orbit fellow of the Aravind Eye System. He's also a fellow of the International College of Surgeons. He's a plastic surgeon and ocular oncologist. He's gonna be taking today evisceration, enucleation, and exenteration. 3 procedures in oculoplasty that we know fully well about. Unfortunately, most of our exenteration, evisceration, and enucleations go without implants, either because of unavailability of the right type of implant or a lack of the specific skill sets to use such implants. And so today, to help us in a theoretical and a practical approach to use of implants, Dr. Oliemi Fashino of the University College Hospital will be taking us on principles of orbital implant use in destructive surgeries like exenteration, evisceration, and enucleation. Dr. Fashino is a plastic surgeon and ocular oncologist of the Department of Ophthalmology and the Oculoplasty Unit. He's a fellow of the L.V. Prasad Eye Institute and also a fellow of both National College and the West African College of Surgeons. Thank you very much and welcome Dr. Ubong Akang and Dr. Fashino. Dr. Fashino's camera isn't on presently, but I've been told that he's with us. Oh yeah, okay, his camera is coming on. Thank you very much and welcome, sir. Yes. So you're welcome. I think I'm supposed to take 5 minutes to introduce us so that we don't eat up all the time. And so Dr. Ubong will take us for 20 minutes and Dr. Fashino will take us for another 20 minutes. And then we'll have a 15 to 20 minutes question and answer session. Once again, we are streaming simultaneously live on YouTube. Please drop your questions in the comment sections of YouTube. It's being monitored. And then if you have questions here, please drop your questions in the chat box. It's also being monitored. At the end of all presentations, we'll take all questions together. Dr. Ubong, over to you.
Thank you very much. Are you hearing me?
Yes, we are very, very clear.
Okay, thank you. Good afternoon, my senior colleague, and maybe others there too. Colleagues, thank you for the privilege to share a few thoughts on this subject matter. I'm always loyal. Thank God I have my chief question on there. Any arrow coming, you should get to him first. You will agree with me that 1 hour won't be enough to exhaust discussions on evisceration, enucleation, and exenteration, with all the matters that would arise from it. How do you do? Constrain ourselves to stay within the 20 minutes. That would mean I have to skip some slides. Just to put a leash on myself, I would like to follow the following outline. Introduction, definition of terms, brief historical overview, brief literature review, especially the Nigerian perspective, findings and indications for surgery, summary, important facts to note about exertion, enucleation, and exenteration, techniques and procedures, and maybe a short video clip on cosmetics, advantages, disadvantages of these procedures, and complications, and then conclusion. I'm supposed to do that in 20 minutes. Okay, so let me share my screen. Is everybody seeing my screen?
Yes, your screen is visible.
Okay. All right. Okay. So I've been introduced already. That's my name. And I'm talking on evisceration, enucleation, and exenteration, which is eye removal surgeries. It used to be commonly known as destructive surgeries. I think we are gentle people in ophthalmology, so just saying destructive surgeries, and the patient hears that, they may think that we are very, brutal, which is not the case. So let's just use the NADA for eye removal surgeries. The above 3 procedures itemized earlier on invariably results in the removal of the eyes, as these are destructive procedures. And it's a very difficult decision for an oculoplastic surgeon, especially if the eyes still have some visual potentials. Difficult in the sense that once the eye is removed, there's no future visual. The decision must therefore be painstakingly arrived at. Presently, there's no viable alternative because of the plethora of indications. It's becoming a common practice, especially because of available cosmetic services. We must, however, know that in some settings, removal of an eye is not a welcome idea, except pains are unbearable. The aim of these surgeries is to remove the contents of the eye or the whole globe, or include the contents of the orbit in a manner that is not a threat to life, and thereafter follow up, with cosmetics. The extent of an underlying pathology determines how invasive or radical the procedure will be. Some patients are afraid to have the surgery, and many don't even desire cosmetics. But with patients, counseling with pictures, and many come around. Just define a few of these terms. Evisceration is the surgical removal of the contents of the globe, sparing the sclera and the optic nerve. This is followed by replacement of the depleted volume by an appropriately sized implant that my colleague will talk about. Enucleation is the surgical removal of the eyeball after exciting the rectal muscles and optic nerve without touching the tumors, conjunctival tissues, and other orbital contents. Exenteration, on the other hand, involves not just the removal of the globe, but also part of all the orbital contents. It can be lid sparing or not, depending on the extent of the pathology. In total exenteration, the lids and periorbital tissues are all removed. where we are dealing with a potential cancerous situation, where the spread has progressed, a more radical exenteration is done, where adjacent structures like bone, muscles, sinuses, and skin are removed. A brief historical overview. Enucleation was first reported in medical literature in the 1500s. The first routine enucleation was done by Norris in 1974. And in 1885, Mills reported the use of orbital implants, a glass sphere following evisceration. In Nigeria, the first publication was on eye removal surgery was done by Professor Olorin in 1973, followed by Professor Money in 1980. After that, a lot of other, studies have been done, and I'm just going to pick on one particular, review that was done by, incidentally, yours truly that is here with me was part of that study, Oba and Dr. Josephine Oba et al. So in a review article on eye removal surgery in Nigeria conducted by Oba J. and et al., these findings were gleaned. Several publications have been done, 21, as at the time of this review. Many more studies have been done thereafter. The study period was 2 to 29 years, mainly retrospective, only one prospective. One of the aims was to elicit some of the common findings on destructive surgeries in Nigeria. It was also to focus on frequencies and indications necessitating destructive eye surgeries in outline, synchronizing facts that may be common in their presentations. The peak age was 30 years, regional tendencies, no specific predilection, gender, male for obvious reasons, which we know. Number of eyes reported was from 29 to 477. This was influenced by acceptance by patients, relations, cultural taboos, and so on and so forth. And the indications were just like I've seen here, trauma and infection topped, the list. Of course, tumors, right down there where either enucleation or exenteration was done. In summary, many studies have been conducted on indications of eye removal across the country and globally. The commonest reason were trauma and infection. Male preponderance. Retinoblastoma was found to be the commonest indication in children. In the study that we did in Nice Center, it was a 10-year study. It was aimed at determining the clinical indications for evisceration, enucleation, and exenteration. Salas, AB, et al. 10-year review was retrospective. It was just to correlate clinical and pathological diagnoses and to evaluate the changing trends over the same period under study. Now, this is what it looks like. You can still see trauma and infection, top to the list, of course. Then tumors, 5, 60, all of that. 200 eyes were done. Indications, you can see evisceration, the commonest surgery done for eye removal. And you can see the whole of this is evisceration. That's the key there. Enucleation here, then you have exenteration, mainly for tumors. So that follows the pattern worldwide. Eye removal surgery is important factor to note. Counseling of patients, very, very important. Use pictures where available. It's more convincing. Informed consent, standard photographs, decide on anesthesia, whether you want to use local or general, then appropriate investigations among treatments. B-scan, you are suspecting intraocular tumor, CT scan and MRI, where patient can afford. So you just take on evisceration. You can see here, the first thing you do after anesthesia is to excise a 360-degree peritomy, where you take that out. This is the peritomy here. Then you excise the cornea button. Then you use your scoop, use your spoon. You want to use to scoop out the uveal contents. And then you can apply cautery. If you don't want to apply pressure, you can use no cautery. So cauterize the central regional vessels and the other vortex and other disturbing vessels. Can now use saline to wash out after you may have applied your alcohol, to take out the uveal tissue. And then we can now create either 2 petals or 4 petals. If you don't want to enter into trouble in your surgery, anything more than size 18, you cannot be too sure that that implant patient will not bring it the next day and show it to you. And so you want to increase the space so that the implant will stay snugly. So that's why we want to do some, some procedures like I'm taking size 20, size 22, or whatever. You can either do a 2-petal. This is 4-petal. All you have here are just the muscles holding these petals. It's 1 petal, get 2, 3, 4, just held by muscles. Would have cut off the optic nerve here, cut it right away. Yeah. So calculating or selection of implant size using the rule of thumb: axial length -2 for enucleation, axial length -1 for evisceration. You can use sizers if you don't want to use this method. And I have a few sizers with me. This is size 12, 14, 16, 18, 20, 22. And then you can use an implant introducer so that you won't really disturb your assistant and all of that. All you need to do is just to put the mouth of this basket like, implant introducer, and you just push it, and it will just deliver the implant into your scleral cord. And so this is it. Now we can still increase, the pocket that is to contain your implant by using your artery forceps. Use the artery forceps to expand it. Just put it that way, and you have. This is where a finger was used to introduce the implant. At times it can be funny. It can even jump out and fall on the floor. But if you use an introducer, it just goes in without any problems. Okay, this is an introducer here. That's how I use it. It fits in snugly into the empty scleral cavity. Alternatively, you can use your fingers, like I showed earlier on. This surgery, we did it last Monday. I had to catch it halfway when I remember that I will present this. So so these are the petals here: 1, 2, 3, 4. Inferior, the superior, the medial, and the lateral. And that's the implant right in there. Okay. Go to the next one. You suture the opposing ones, superior to the inferior, and all of that. Okay. And the next one, the superior one has been done, See, now the lateral and the medial ones are being done now. We don't have much time, that's why I'm just skipping, so that's it. And then you now go, you look for your tenons, separate your tenons from the overlying conjunctiva, underlying sclera. That's the tenon that is being separated. And the tenons has been separated there. Okay, jump that one. And then the suturing. Okay. You finish with the tenons. That's the conjunctival suturing that's being done there. Continuous. The tenons suturing is interrupted with 6 vacuole. And you now put your tasseraphy. Okay. All right. So this is what it comes up with. This is how pre-op. Okay. First up, after you've removed your tasseraphy and your conformer, this is what it looks like. Compare this. She squeezed this eye. Now look at this other eye. It's almost, apart from these dimples here, from sutures. Okay, it's almost that's how it is after 6 weeks. All right. So enucleation, the technique, mild conjunctival, give your local anesthesia, 360-degree peritomy. Just describing. Let me just show you a video. I'll just show a video for that. This is from courtesy of the Center for Sight. The video.
By the mic.
So enucleation by the mild conjunctival technique. You can see that. You can determine your peritomy. The extend the tenons with the tenotomies, tag the muscles, Touch the muscles, cut it off, cut all the muscles. You support your globe with the tag that you did earlier on. And then you go for you strum at the optic nerve so that you can get the longer optic nerve length. That is strumming that is being done there before you cut it. After cutting it, you will now inspect your globe. Also inspect. Take out at least 15 millimeters. Can take up to 25. You now put your implant posterior to your posterior tenons. You now close the posterior tenons, interrupted stitches, and then you now close the conjunctiva. Okay, advantages: evisceration is better, gives better motility, lower risk of bleeding, less manipulation, less inflammation, and less scarring as a result. Simpler performed. Larger implants prevent thymus and superior sulcus deformity, and so you can do your 4-petal or 2-petal, so they can put larger implants. The enucleation is less painful. Extensive globe disruption following trauma. You prefer to do enucleation, where tumors are suspected. It's better to do enucleation. It allows for complete specimen for histology. In primary ocular malignancies that are not amenable to alternative modes of therapy, you can do enucleation. It allows for complete eyeball examination, like we just saw, an optic nerve examination. Surgery of choice if pathology is powerful. Reduces concern that surgery may result in sympathetic endophthalmitis in the long run. Okay, so complications. You can remove the wrong eye. You always make sure that you keep cross-checking your eyes. Ptosis and extraocular muscle damage that happen, bleeding intraoperatively, wound dehiscence, post-op, disruption of orbital anatomy, because a lot of manipulations, implant migration, extrusion, socket contraction in the long run, in deep sulcus deformity, we mentioned earlier on. Then for exenteration, we mentioned that point earlier on. The first person to describe it is George Batich. The modern exenteration was described by Alt. Now, it's done mainly for malignancies. You are seeking for tumor-free margins, so you can even go as far as the bones, for extended exenteration. But these are the common ones you can see. Squamous cell carcinoma, basal cell carcinoma, sebaceous carcinoma. Others are conjunctival melanoma, adenocystic, adenoid cystic carcinoma of lacrimal gland, uveal melanoma, and so on and so forth. We use GA except where it is totally contraindicated. GA is the choice anesthesia to use. So you can see this skin incision 2 millimeters below the cilia. The skin incision is completed, soft tissue directed to the rim. Always aim for the orbital rim. It makes life easier. Use backpacker or your RF cutlery, to just cut over the bone there. That's what you do. And then peripheral elevator, you use to elevate it from the bone while putting the peristome on stretch. Enucleation scissors is used to cut out the optic nerve and other tissues. This is the view of the lid after you've removed everything. Such as after granulation or after granulation, this is what you see. And then you can do a spectacle mounted, processes. So this is what these are the type of things we see. For a more complicated case, more than this, you may need the services of an anaplastologist. Look at this one. This one went. Okay, that's a hole right there. That's a hole there. Was an extended, exenteration. Now the processes that was done here by an anaplastologist, all of this that you're seeing here is part of the processes. It was like a big flap. All of this. And you can see the woman looks almost like the other side. It's an art, in I said that this is what we do, this course of our ocularist. If we have something like this, there's no point trying to think whether you can salvage this. You will do more damage. Just send patients so that the ocularist will make a spectacle mounted prosthesis. As you can see, this is not bad at all. Tips for exenteration. You are likely to encounter the following. So you have to transect all of these vessels here, transect them before you go to the posterior orbit when you do hemostasis. And allow for granulation. You don't want it to granulate. You can do a split thickness skin graft. You can use local flaps, cheek lift, medium forehead flap. More recently, you have integral dermal regeneration template, which is an advanced bovine biolayer silicone and collagen dermal replacement template, which good success has been recorded so far. Extensive bleeding can take place. CSF leak. Well, we did one with my professor, Professor Usha, in Arabic, and we ran into the Edmond. The thing was scattered. It was just leaking. She had to call the neurosurgeon, and we were guided. Post-op infection can be controlled by appropriate antibiotics. Sloughing of your skin graft, you can allow it to granulate. It shouldn't be any issue. Intracranial infection, if you want to prevent it, you can just obliterate the cavity. So in conclusion, I just had to rush through it. Eye removal surgeries are common procedures in Nigeria. Trauma and infection tops the list of indications. Retinoblastoma remains the most common indication for surgical eye removal in children. Evisceration is commonly more performed than enucleation and exenteration. Before now, eye removal was like handing out a death sentence, pronouncing a death sentence on your patient. But with the advent of good cosmesis and counseling, the uptake of surgery has taken up a positive turn. More innovations in eye removal surgeries and cosmesis is still ahead of us. The future looks very, very bright. Thank you. Thank you. Thank you very much. Hello, moderator, are you there?
Yeah, thank you very much.
Okay. I hope I was within the time.
Oh, yes, yes, you were very within time. Very, very within time.
Video, so I wanted it to show.
Yeah.
But it's okay. I'll just get something out of it.
Thank you
very much.
Yeah. We'll revisit some more points during the Q&A session. I'm very sure that we'll have lots of questions during the Q&A session. So please just remain with us, sir.
Okay.
And so our next speaker is Dr. Fashino. He'll be taking us on the principles of orbital implant use in exenteration, evisceration, and enucleation. You can go ahead and share your screen, sir.
Okay, thank you very much. Is my screen visible now? And am I audible?
Yes.
Okay, thank you very much. Let me say that it's a pleasure to be here this afternoon. And Dr. Akang has actually made my work a lot easier. He has touched virtually everything from the procedure up to the implants use. So basically, I will just add a few things on this, and I think we can go into the Q&A session appropriately. So basically, what else during the next few minutes, we'll review the historical perspective related to use of orbital implants and the changes in practice pattern that had occurred over the decades, and maybe a little bit of understanding of these implant designs, and to a certain extent have a greater understanding of implant and prosthetic mobility, because that's one of the main essence of inserting an orbital implant following eye removal procedures. Now, over the years, we now have a greater understanding of the anatomy of the post-enucleation of it. In the past, it used to be something mystical. So at the onset, no implant was being inserted after enucleation was done. We just leave the orbit to granulate. And certainly this caused with a lot of complication from infection, and invariably the cosmetic resultant cosmesis is quite poor following this procedure. So over the years, there has been significant evolution over the last 50 years in the design and philosophy of orbital implants use following eye removal procedures. And of course, this had ensured that I now have better cosmesis and reduce the complications following all these procedures. There's no point after removing the eye, since we know the functions of the eye, apart from the vision that it subserves, it also gives cosmesis. So if you don't lay a good foundation by putting the appropriate size implants after removing the eye, it's going to affect the prosthesis or artificial eye that's going to be worn by the individual after healing has taken place. If we go through the historical perspective, you know that all this started by even in Egypt, by using of wax to fill the orbits, on top of which precious stones that simulate the iris they are used during the process of mummification. Gradually over the years, the Romans and Egyptians started using clay prostheses that are one over disfigured globe. These are just initial attempts at giving better cosmesis following either a disfigured eye or after eye removal has been done. The early records of evisceration and enucleation in the living actually started at about, we could see that from the 16th century Europe. At the initial stage, is basically a kind of subtotal exenteration to just extirpate the eyeball without anesthesia and, of course, with granulation of the orbit. But this has actually been jettisoned because following this procedure, I mentioned before that prosthesis was not possible. However, by the end of 19th century, replacement of spherical hollow glass in the eviscerated eyeball and enucleated orbit now came into being. However, at this stage, because the design was so that there is so much of rough edges with rubbing of soft tissues with these devices, the extrusion rate was very high at this period. So that over the years, there be improvements in the design and also the materials being used in design of these implants, so that there's now better a reduced rate of extrusion and other complications that may ensue. And of course, by the time we get to the early 20th century, conformers are now being placed at the time of primary surgery, which is like temporary prosthesis, initially made of glass materials. But basically, the idea of the conformer is to keep the fornices well formed during the initial early process of the first few weeks postoperatively before the artificial eye or prosthesis will be worn by the individual. It's also helps to reduce postoperative edema that may form if the conformer is not placed into the orbit. Now, once the eyeball is removed, it's a volume loss has actually occurred in the socket. So definitely that volume loss has to be replaced. Because after the eye removal has been done, the ultimate goal is to wear a prosthetic eye. So we saw the pictures shown by Dr. Akan earlier on, the prostheses that are worn by the patients who have had enucleation or evisceration. The good cosmesis, the good fitting that we could get from this actually stemmed from the fact that an implant had been used to partially replace the volume loss after the eye had been removed. So if this was not done, the thickness of the prosthesis is going to be so that the good cosmesis cannot be achieved. Of course, the benefits of use of implants include that it reduces socket contraction. If you don't replace the volume that had been lost, the soft tissue within sockets will certainly contract. And as such, there is going to be kind of reduction in the volume of the socket following contraction that occurs with wound healing. Also, there is redistribution of the orbital fat, which now sinks inferiorly, and as such leading to greater accentuated superior sulcus deformity. So all this will also ultimately affect the cosmetic effects that I would advise that you can get following prosthetic wear in these individuals. Also, the use of implants permits the use of smaller, lighter, and thinner prostheses, so that it's not as if you are going to use a very thick prosthesis, because the thicker the prosthesis, the less the amount of excursion of the prosthesis with eye movements, and ultimately the cosmesis is not going to be as good as it should be. Also things like reduction of lower lid ectropion and so on and so forth. These are the advantages or the benefits of placing the appropriate sized orbital implants after eye removal procedure has been done. There are so many types of implants. This table just shows, or this slide shows us the common ones that we have, the biocompatible ones, the hydroxyapatites, the PMMA, polymethyl methacrylates, silicone implants, and also the Demis fat grafts. And on the other side, glass. These are just different materials that have been used in design of the orbital implants that are commonly used or that are available. And these are just pictures that these are things that we use commonly at the silicone implants and the PMA. These are the implants that we use, also the PMMA implants, and so on and so forth. Now, following enucleation, we know that on the average, there's about 5.5 to 9 mil of volume loss, average of 7.5 to 8. Of course, this also depends on so many factors. That's why the range is there. Of course, in the myope, the amount of volume loss is going to be much higher than in a hyperope, as the case may be. As such, the size of the implant that is going to be placed should also not just be generic. As much as possible, we want to place an implant that is close to the eyeball size that has been removed. Dr. Akang mentioned earlier on that we can use sizing implants to give us an idea of the size of the socket or the volume loss within the socket, which can be done on the table. That will give us an idea of the diameter of the implant that is going to be inserted. Or in a patient, or at times you can just use the caliper. If you don't have sizing implants, you can use a caliper to measure the diameter of the enucleated eyeball. Or in a patient who has or for example, if a patient has a classical eyeball that has been enucleated and it's so that it's going to be difficult to know the exact axial length, then an A scan could have been done preoperatively on the contralateral normal eye, and the idea is to replace about 70 to 80% of the volume of that particular, either the measured enucleated eye or following a scan of the contralateral normal eye. The formula that he gave has to do with the implant size. Roughly is just the axial length minus 2 millimeters while dealing with enucleation, minus 1 millimeter while dealing with evisceration. Dr. Akan mentioned that earlier on. The reason why we remove this is because we know that an additional volume is still going to be added onto this by the prosthesis. So we need to give that allowance for additional volume replacement by the artificial eye in these patients. And this is just a table that shows the different diameters of the implants and the amount of volume replacement that you have. On the average, the 20 millimeter implant will replace about 4.2 millimeter cube of orbital volume. I mentioned that before. So the remaining, so since we know that following enucleation, about 7.58 mil of volume is lost. So if the 20 millimeter implant gives a replacement of 4.2 on the average, the remaining 3 mil can actually be given by the artificial eye or the prosthesis. So since we know that on the average, give or take, many of the prostheses come with the volume of 2.5 to 2 to 2.5 mil, because the heavier the prosthesis is, we have mentioned before, is going to form a weight that can cause lower lid laxity, so that the maximum tolerable volume in terms that the orbit, most orbits can cope with is about 4.2 mil. So we want to avoid having to use a thicker prosthesis because of the other complications that may ensue. So the greater part of this volume is going to be taken care of by the orbital implants intraoperatively. I mentioned before that if you use a fairly large sized implant, you mentioned before that you don't want to use a too large an implant size, because one, there's high risk of extrusion in the early postoperative period, because following a large size implant, the tenons that you are going to use to close that you close over the wound is going to be under tension. Of course, you know, the greater the tension, the higher the amount of extrusion following vascularity compromise and so on and so forth. A too large sized implants will also prevent fabrication of prostheses with enough AP depth to give an appreciable anterior chamber perception following the design or fabrication of the prosthesis. Also, if the implant size is too large, it restricts prosthesis movements, because the large size implant will crowd the fornices, and as such, movement of the prosthesis is going to be impaired in this individual. I'm looking at the concept of implant integration. Basically, we're talking about the nature of the fit between the implant and the prosthesis after the prosthesis has been inserted. And basically, you'll talk about 3 different classes. Talk about either a buried implant. In buried implants, there's an uninterrupted conjunctival lining over the implant. So it's completely buried within the socket. And as such, following the smooth apposition between the prosthesis and the implant, which has been covered by the conjunctival lining. You can also have exposed integrated implants where the conjunctival lining is interrupted. This enables, these implants, they are designed so that there could be coupling, direct coupling between the prosthesis and the implants. The idea behind this is to give a better mobility to the prosthesis, as the case may be. Of course, it has its own complications. Or you can also have buried integrated implants where the conjunctival lining is also uninterrupted, But the implants, this type of implants, they have irregular anterior surface so that they're able to key in onto the prosthesis, giving rise to better cosmesis. All these ideas to give rise to a better movement of the prosthesis over the implants that are being placed intraoperatively. Now, the earlier implants, they are not porous. They are like the PMMA, the silicone. There's no vascular base for them. And as such, the risk of exposure is much higher in them. And when this happens, it's much difficult to repair. So this led to development of what they call the porous implants, the hydroxyapatite, the porous polyethylene, and aluminum oxide. These have tiny pores within them that encourage vascular ingrowth into the implant. So they kind of get integrated into the socket. And as such, the advantage of this include that surgical repair of patching of the graft is possible. Even there's little exposure of these implants. There's also reduced implant migration exclusion because of greater integration between the vascularized porous implants and the sockets. Also, there is reduced orbital infection because you're talking of vascularity that's much better in this kind of implants. When I talk of adequacy or the motility of the prosthesis over the implants, when you have about 70 to 75% movement compared to the contralateral side, that is quite adequate. Of course, the higher the percentage, the better the or the greater the better the outcome of the procedure in this patient. The idea is that so with this, there's the edge show on the prosthesis is not that much, and there's also the end gauge torsion of the prosthesis is minimal. Whereas in inadequate prosthesis mobility, there's poor implant mobility. So this can be due to either the implant is a small sized implant, so that there's some measure, a great measure of space between the prosthesis and the implant. And as such, the movement of the prosthesis while the implant is not adequate, or there could be lack of direct translation of movement between the implants and the prosthesis. So for this is going to be much higher in the buried implants compared to the buried integrated implants, or where there's a large, after using a large sized implant with crowding of the fornices so that the fornice becomes inadequate. This also leads to reduced motility or mobility of the prosthesis post-operatively. In children, of course, we also have eye removal procedures in children, mainly following malignancies. Retinoblastoma is quite common in this environment too. So initially, there's that hesitance about, do we also place implants following eye removal procedures in children? The reason behind it is that most, as I mentioned before, most of the times is due to tumor. Maybe you remove the retinoblastoma, the eyeball with retinoblastoma. So the fact that these children may actually develop recurrent tumors, and if an implant is there, it may actually make it a bit difficult to know early recurrence of tumor. But over the years, normal, so we know that there is definite need for orbital volume replacement in children to allow for orbital bone to grow. So there's no controversy about this anymore. Implants must be used in children. Also, we know that the adult orbital volume, the bony volume, is attained by 12 to 40 years of age. And by the age of 3 years, 80% development has occurred. And that's why these first few years of life, they are quite important to replace the volume with an implant, thereby stimulating the orbital growth. Otherwise, if this is not done, there's going to be bony contraction, which is going to be much more difficult to manage later on. Mentioned before that points to note about in children. So now the use of porous implants in children is quite remarkable because it causes fibrovascular ingrowths in them. So one way to look at it is that if there is need to do an implant replacement, it's going to be more difficult if a porous implant is used in children. And a child who has retinoblastoma that may also need to undergo external beam radiation therapy. If a porous implant is used with its fibrovascular ingrowth, the chance of extrusion is much higher after external beam radiation. The hydroxyapatite, for example, is radio opaque. So occasionally, since we know that one of the features of retinoblastoma is calcification. So if care is not taken, this may mimic recurrent retinoblastoma, whereas it's just an already opaque hydrosalpingosis. So these are facts that we need to take into cognizance when using porous implants in children. The acrylic ball implant is quite the mobility. There's good mobility with when ocular muscles are attached to the cornices. Dr. Akan mentioned that in the mild conjunctival technique, and it permits readily an implant exchange. If you want to place a larger size implant after a few years, it's readily it's much more easily possible with this compared to the porous implants. But more importantly is the dermis fat graft, which can also be used in children because it has a good growth potential in the sense that it can also develop, because this basically we are talking of harvesting the dermis fat graft in the periumbilical region and placing that to replace the volume in the socket. So there's tendency as a child is growing for this to also develop. However, there's an unpredictable graft uptake because for it to take, the vascularity of the recipient bed must be good. More so if a patient is going to have an adjuvant radiation therapy, it can result in necrosis of the dermis fat graft that have been implanted. And of course, there could be hypertrophy. Trophitis are just some of the drawbacks of using dermis fat grafts in children. Many of the complications of implant placement I've mentioned before: implant migration, implant exposure extrusion can occur at any time in the early postoperative period to the late postoperative period. Use of heavier or larger size implants can predispose to this. If you close the wound, other tension. The videos shown by Dr. Akan has explained that these are things that can give rise to implant exposure or extrusion. There could be low mobility transmitted to the ocular prosthesis. Reasons for this I've explained earlier on. Of course, there could be infection or inflammation of the socket. If the socket gets infected, there's higher chances of implant extrusion or exposure. Pyogenic granule can form. Many times, when you want to close the conjunctiva, you can use a pulse string suture to ensure that the conjunctiva is actually pouched out, the edge is pouched out, so that it does not roll in, giving rise to pyogenic granuloma or cyst formation. Of course, that the conjunctiva is carried, that could be ectropion. If a large-sized prosthesis is fabricated by virtue of the fact that a small-sized implant is used, it can form a weight and costular lead ectropion. Encapsulation can occur, ptosis can occur, superior sulcus deformity, and so on and so forth. In conclusion, we know that eye removal procedures, they are drastic decisions that has been explained before, and there are specific indications for it. Definitely, once the eyeball is removed for any reason, there is resultant volume loss, and this certainly needs to be corrected. Over the years, there is evolution in the implant design and materials selection that are taking place, which invariably has resulted in better clinical outcome for this in these patients. And even over the years, even till now, there are still further modifications in the materials that are being used or designed, so that they now start thinking of smart multifunctional implants that have some antibacterial property with better cosmetics and so on and so forth. Just a little to add, for exenteration, we certainly cannot use implants because there's no place where the implant can stay after having removed virtually every content of the socket, with the sockets now being lined by the skin. So the exenteration prosthesis, as highlighted by Dr. Akan, is the way to go. So the implants used basically has to do with evisceration or enucleation. Thank you very much for listening.
Thank you very much, sir. I'm very happy to say that we are very much on time. It seems that people in oculoplasty keep to time a lot. They know how to work with time. Thank you very much again for your discussions. We hope to spend the remaining 10-15 minutes with a discussion type of Q&A session where we hope that both presenters will share their wealth of experience and knowledge practicing in our kind of resource-constrained environment on the best way to go for exenteration, evisceration, and enucleation. Yeah, the first point we want to have some discussion want to touch on conformers. Most of our practices do not have access to conformers that can be customized to a patient or have a wide range of sizes to choose from. So in situations where we do not have this chance to choose from a wide range of sites or conformers to use on table post enucleation or evisceration, what has been your experience in getting substitutes? What can we use to keep the furnaces patent pending within the next few to 6 weeks before we put an appropriately sized conformer?
Thank you very much. Well, it may not be totally true that they are not readily available. I think in recent times, they are much more available now than before. However, I know there is a particular study done that encouraged even the use of primary prosthesis being inserted on table. So if, for example, you do not have any the appropriate or near appropriate conformer to use, even if you have an artificial a stock prosthesis, that can also be used. Only that you know that a stock prosthesis is not fenestrated, there's no hole, and as such, edema can occur and hematoma can form. But if you have closed your wound tightly enough and you've maintained and secured the hemostasis, that shouldn't be so much of a problem. So in the absence of that, but I still maintain that the way to go is to get a conformer which is not too difficult to acquire, but that can also be used. But it's always better to maintain that the furnaces, otherwise furnacial contraction can take place and that can also reduce impair the fabrication of customized prosthesis. I think Dr. Aka wants to say something.
Yeah, I just want to add, if you want to get conformers, it is easy to lay your hands on them, because I think it's very important you use the proper material for the proper thing. You have different sizes from size 18, 20, 22, right to 27.
Right and left.
And yes, right and left. And you know how to identify the one that is for the right and the one that is for the left. So I think one should go for it. What it does is that it insinuates itself to superior, inferior, furnaces and all of that, and keeps it. By the time you apply your tarsography, sutures, it pushes the edges of the conformer, and gives you that, phonics, that shape that it ought to be. Otherwise, I don't know what they do, apart from the stock, processes that he mentioned. Is this a fragile that you will put? That will not give you, the push towards the furnaces. You just go for the right thing. It's available everywhere.
Thank you very much. Thank you very much. So this question comes to also Drs. Fashino and Dr. Akang. What's your choice of anesthesia? What's your go-to choice of anesthesia for evisceration and enucleation? We know exenteration is general anesthesia, no arguments about that. But we also know some people prefer local for evisceration, and some people prefer general anesthesia. What are your thoughts on the best form of anesthesia for evisceration or enucleation? Dr. Aka.
You want to take that?
No, you can take it. You can take it. You definitely
okay. Initially, when I started, a few times we did it under GA, but this is an eye that you're going to destroy. Oh, pardon me for using that word. To remove, so you can give as much LA as possible to make sure that there's no pain. It's not like cataract that you say, oh, if I give more than 5 or 6 mils, it's going to increase the pressure of the eye. All that stuff. No, you're not afraid of. He that is down does not fear any fall at this point in time. So you give that local, patient calms down, and you do it fast. These days we do it quite fast. So patient does not even feel. It's just wondering if it's that 14-year-old boy, 12, 13, will he be able to stand it? You just ask them. At times, some of them stand it too, but for those older ones, LA. But for the ones that are quite jittery, it's better you go for GA, but tell the patient about it. Do you want to spend more money and all of that? Some of them, by the time they know that they'll spend more money, they make up their minds to go for the LA and all of that. That's just,
Yeah. Okay.
I
So
use LAs mostly.
So this brings us to the okay. Dr. Fashion, you want to say something?
It's not total. It's not a different experience. It's early is good to go, really.
Okay. So this brings us to the next question. Knowing that we're removing the eye for this patient, there's an emotional component to this procedure. Do we consider the fact that this patient may have some psychological reaction to the fact that he's awake or she's awake while the eye is being removed? And this takes us back to consent taking. Who takes the consent? The surgeon or a dedicated personnel or a counselor? What makes optic better and what makes the whole process in theater more acceptable to the patient?
Well, let me just start off by saying you have raised a very valid point. Eye removal procedure, it's not a palatable thing, really. Nobody wants to lose his or her eyeball. Some will not even agree. So certainly you need to consider the psychosocial aspects, as well as the psychological status of the individual, and which also merges with the consent. The consent in eye removal procedure is not a once and for all. You start preparing the patients right from the clinic, right from the first visit, to the time you book the patient, to the time the patient is admitted, and if to the time the patient is going to the theater. And if at any point in time, that's from my experience, the patient seems not convinced again, I might cause to discharge the patient after admitting the patient for eye removal procedure, and they send the patient back to the clinic. Because as of that time, patients started becoming uneasy about the removal. More so if it is not for an urgent reason in the sense that malignancy. If it's a painful blind eye, the patient can still bear the pain. It's no big deal. But for malignancy, you go an extra mile to convince the patient or the relative of the need to have the eye removed. And that brings us to the next question, that it's almost criminal to remove an eye without sending for histology. That should never, ever be done. Even if the histology is going to come back and tell you that this is normal tissue, please get it be done. So that's by the way. So the concept is not like cataract that you just gather the patients together, you are going to have cataract surgery tomorrow, you are going to see better, or the full compression may occur. No, in this situation, the concept is it takes a longer time, and the patient must be psychologically prepared before you remove the eye. Of course, you show pictures of those who have had their eye removed, who are wearing prostheses. So these are things that will also help to encourage the patient to accept the procedure. Yeah, Dr. Akan.
Yeah. If one has a good ocularists who have turned out some very good, results, it becomes a bit easier. Just sits down there, talks to the patient, brings out pictures. This is how this patient looked like. This is how it has been after surgery. By the time they keep talking to them, they get, motivated, to go in for the surgery. I also spend time to talk with them. I crack a lot of jokes with them. Of course, when I enter the theater, I go in as if I'm jogging, as if I'm going to do, patients start laughing and all of that. They get so, relaxed and all of that, and they're happy most times. So it's how you handle the patients. But there could be some very stubborn ones. Some of them that are lawyers, when I see that L, I say, you have to watch this back carefully, you understand? Because those are the ones, when they ask too many questions, just sit down. Don't just rush in to do it. Keep talking to them until you are sure that this young man will not, broadcast your name, all over the world. So you have to watch your patients. Bottom line.
Okay, so the follow-up question is, do we routinely provide continued psychological care or continued counseling and discussion with our patients post-surgery? And do we have experience on post-surgical depression setting in because of a loss of an eye, despite whatever reason? Or is this something we haven't really exhaustively or conclusively talked about or thought about? Or is it a thing? Psychological distress following, even those who've had successful surgery, there was some psychological distress or residual psychological distress following this?
Well, it's like we mentioned earlier, if you do a good pre-operative assessment and counseling, over the last over 10 years that I've been actively involved in this, I don't think I've had cause to encounter this. The most important thing is to preempt this and manage it pre-operatively, so that, like Dr. Akan said, they are happier for it. I could remember one of the experiences that I had. A mother came with, I think, 3 or 4 months old baby that with retinoblastoma, we had to remove the eye. And after the healing has taken place and we put the prosthetic eye, the mother was shedding tears of joy, because she could not believe. It was so dramatic, really. So these are the kind of experience that we have if you have done your preoperative assessment and counseling very well. It shouldn't lead so much into, but as we mentioned before, of course, counseling, psychological encouragement is supposed to be an ongoing thing, which should not stop even in the post-operative period.
Thank you very much. On the comment,
where we are even having problems is even in the area of these ones that come with congenital anatomas. No, no eyes whatsoever, and we keep looking for expandable silicone implants that one could just at least put something in there that will absorb water and expand and stay there for quite a, just to make sure that the orbit, grows as the child is growing. But I'm finding it difficult. I don't know whether anybody, Dr. Fashina, have you been able to lay hold on expandable silicone implants?
No, I have not.
We have some cases, about 3 or 4. They've been on my neck.
Maybe the way to go is to use the acrylic or the PMMA implant which you replace after a while. That may be another way to go, but I have not been able. I know that should be the way to go, but that may be difficult to get in a resource-limited environment that we're practicing in. Maybe some of our other colleagues may chip in later on when it comes to the general contribution.
So the next one has to do with your experience with primary and secondary orbital implants, especially in the setting of 1, children with retinoblastoma, and 2, infected orbits at the time of surgery. What's your experience with primary orbital implants in children with retinoblastoma? Or do you opt for a secondary implant, or we put implants primarily on table and watch? And then in patients who have very infected orbits that need surgery, do we opt for secondary, or do we also do primary orbital implants in such patients?
Yes, for retinoblastoma, intraocular retinoblastoma, they had been enucleated. We mentioned before that primary implant is the way to go. There's no doubt about that. These are children that the orbital bone is still developing. The other one has to do with when there's infection, the setting of infection, the chances of extrusion is much higher. And as such, a secondary implant may be a way to go. After, you just need to control that infection, either preoperatively, but if you cannot do that and you want to eviscerate, it may be wise to allow the infection to quieten that and you place a secondary implant. That's what I do in my practice.
Okay, so what is done to
I don't get worried about secondary impact, implant these days, because I just go for Demis fat graft, and I've had good successes with it. The very first one I did around 2009, 2010. Anytime she comes around, I'm always very, very happy. I show her around. Demis fat graft, very good. It allows you to have enough phonics to play around with, both superior and inferior, and then it gives you volume. Oh my! so I don't worry about the secondary, implants. If I cannot do it, primarily, I know, surely. I'll get it done secondary.
PFG is a form of implant, so anyway.
Yeah.
Okay, so in patients, we don't put primary implants. How long should we wait? Let's assume we control this infection properly. Would 2 weeks be fine? And within that time, do we need to maintain orbital volume, or it doesn't matter so long as we're doing it within 6 weeks? For patients who are planning secondary.
For a short period of time, I don't think the orbital volume replacement matters as such. It's just that the conformer has to be placed in to ensure that the furnaces are well formed, even during because with infected tissue, if they heal, the amount of contraction is going to be much more severe. So the conformer has to be in place while the infection is getting controlled.
Okay, thank you very much. Someone is asking if use of normal saline on table can be used to estimate the volume of the orbit in patients we are having enucleation or evisceration done if we do not have implant sizes. Apart from using calipers from measuring, can normal saline be used to estimate the volume? I don't know.
I do not, maybe I do not understand how the normal saline.
I think you just go for size 18. You know, if you are not doing a 2-petal or 4-petal that can get your implant to fit in snugly without any tension, just go for size 18. You know, it straddles across what will keep you comfortable. Instead of using water, water cannot really help you to estimate the size of the implant.
Okay, and talking about petals, you mentioned petals, Dr. Akang. When making your petals, how deep should you cut your scleral pockets? How far back should you cut to be able to get good petal opening?
You cut it right down to the optic nerve and then cut it, you know, excise it, leave so that the optic nerve will just go. The leaves are just hanging on their own with the muscles holding it.
Okay.
You understand?
Yeah. Okay, so following that, you use interrupted vicary cis-O sutures. Is that a personal preference? Also going to Dr. Fashina, or do you have personal preference for type of sutures used in closing up your scleral pockets, your tendon and conjunctiva? And is it a personal preference to use interrupted, or can we use continuous? Or do we have data that makes one more suitable for such situations than the other?
It's better to use, at least for the posterior tendons and so on and so on, it's better to use interrupted so that in case of any little hematoma that wants to form, it can seep out from the interrupted suture compared to when you use continuous. I don't use continuous until possibly I get to the conjunctiva, in which case I would have closed the posterior tendons, maybe close the sclera, close the anterior tendons on top of the implants. And of course, by that I know the hemostasis is well secured. You cannot use continuous for the conjunctiva. You can still use interrupted for the conjunctiva, it doesn't matter. But the idea of using interrupted at the deeper levels is to allow seepage of serous fluid to come out and not form a hematoma that can get infected within the sockets or form a pouch within the socket.
On the other hand, if you do continuous and if by mistake it cuts, the implant just comes to greet you the next few days. That's just it. The patient comes to you and says, "This is what came out of my eye. I would want to give it back to you."
So is vicary cis-O, which is what you, Dr. Akang, you say
that, you know,
yeah, is that your preferred suture, or is that the best for enucleation or eviscerations?
It's a preferred suture for me, and moreover, almost all over the globally, most surgeons will use that.
For most eyelid, we use 6-O, either vicary or prolate, depending on the procedure you are doing. So 6-O is quite popular with oculoplasty.
Okay, and so we're not worried about wound breakdown. Are we confident that within 6 weeks healing would have taken place enough, and then no one breakdown at that time.
Yeah.
Okay, thank you very much. And someone is asking, just give me a minute, please. Someone is asking, granulation versus non-granulation. Is there any preferred situation? Do we want the socket granulated, or do we want to use it without? Because Akan mentioned about using a graft if you don't want the granulation tissue to form, or even if the tissue's graft sloughs up and granulation forms, is not a problem. Do we really need to worry if granulation forms or not? Is it something we should be worried about?
What did I personally?
Yeah,
I don't even use all those flaps. I just allow it to heal by granulation. What I was trying to say is that if you had put in any flap or any of those things and it sloughs up, don't worry, allow it to heal by granulation.
Okay, Dr. Fashina.
Granulation means healing by secondary intention.
Yeah, secondary intention. That's what I mean.
Yeah. Still going back to do further reconstruction later.
Okay. More on extrusion, SARS. We mentioned them not making sure we don't close the implant under tension, and we use interrupted sutures. What other ways can we apply to make sure, and they use appropriately sized implants? Are there any other ways to prevent extrusion, apart from these three major points that we've talked about a lot during the process of this discussion?
Ensure that bleeding is controlled. If hematoma forms within posterior to the posterior tenos, that is within deep in the apex, the chances of extrusion, because the volume will increase, and even your interrupted sutures, by the time 2 or 3 or 4 gives way, definitely that can result in extrusion. Of course, we want to do this under asepsis, because if there's infection, chance of extrusion is also much higher. Maybe Akan wants to add a few things to
it. No, that's just it.
Okay. Still on extrusion, what's your preferred go-to or line of principles of care for patients who present with extrusion? Do we go back immediately to reimplant, or do we give some time, antibiotic cover, then reimplant?
Well, it would be nice to know the cause of the extrusion. If it's due to an infected socket, definitely you have to allow infection to settle. If there is a large clot that has formed posteriorly, posterior tenos, you need to evacuate that. And if you think that it's clean enough, emphasis on that, you may actually go in and replace the implant. So it has to be on an individual basis, depending on what actually caused the extrusion in the first instance. But if you think, like Dr. Aka mentioned, you may not even need to rush as such. You can always go back if you are not sure of the status of the socket. Let the infection, let the inflammation, the edema and everything, because by that time there will be some measure of edema. So let this edema subside. And if you are trying to suture tenos when the tissues are edematous, certainly the sutures can cut through. So we actually allow the inflammatory edema to subside before you go in and reinsert the implant. So it has to be on an individual basis.
Okay.
I remember one patient, retinoblastoma patient that came to us. We saw the patient before we knew it. She took off to India. The mother took the child to India. They treated the child, inserted an implant. By the time they came back, the implant had extruded. They went to Lauren. They fixed another implant. They extruded. Whether they did it the third time somewhere. And they now came to eye center. And after we had finished everything, wanted to do surgery. We discussed with the mother and all. The father stayed somewhere and said that it should be a ball implant that should be put. So that when they go home, they will now bring it again and show it. They'll be mentioning names. The one that was done in India came out. The one that was done in Lauren came out. the one that is done in that center has come out. I said, go and tell your husband. If he doesn't want the extract graft to be done, you are not touching your eye. And that's how they kept on jumping up and down. Eventually, they came back and we did a demi-strat graft. And the child is so happy to do it for them. The thing has been there for some years now. So you just have to make up your mind how you handle these things. Otherwise, even the patient can decide to fluster you.
Okay, thank you very much, sir. Yeah. I think Dr. Alice Ramil says something about, we talked about implants for anophthalmic patients. In the comment section, she says use serial conformal insertions for congenital anophthalmos, just like Dr. Fatima mentioned, use of repeated PMMA insertions. So, repeated PMMA
Well,
insertions.
these ones that come, everything is plastered together, it's just skin over it. It may be a redundant tissue somewhere. So there's no place that to even say you want to put, there's nothing you can place on the outside. It's just to do surgery, open up, where you think the lead could have been, dig it, dig in and then insert some implants and then close it back, just to make sure that the orbit will grow, without any sort of asymmetry, sometime in future. So I don't really see where a conformer would come into that now. So that's what I'm talking about.
All right. And so someone says extended enucleation. If you could throw more light on extended enucleation. That's one of the questions we have here.
Enucleation is enucleation. When you're talking about extension of something, that should be about exenteration. When you say extended exenteration, it means you go for the bone, remove everything that you think the tumor has, any area you think the tumor has spread into. So that's like a radical exenteration, an extended exenteration. I don't think you mentioned anything about extended enucleation. I don't know. Did you hear anything like that, Dr. Fashino?
So the concept in which some people use the extended enucleation has to do with when the possible as at that level, it may be difficult to actually do a pure or proper myoconjunctival technique. You cannot get the muscles to attach to the furnaces. In some cases, maybe there's a recalcitrant extrascleral extension of an intraocular tumor that has to actually, that at that level, in that particular quadrant, you may actually need to take some orbital tissue off together with the eyeball. Of course, that patient certainly, apart from continue the chemotherapy, we also need to undergo our external beam radiation to the socket. But so those are a bit far-fetched, which is not such a common thing when you have some tumors that are just recalcitrant to even the probably maybe the patient cannot undergo the high dose chemotherapy that is being used. So at that particular quadrant, we actually need to delve in and take part of the orbital tissue off. So it's not the pure eyeball in total removal. You may actually need to delve in and take some of the orbital tissue. That's the concept of extended enucleation.
Okay, thank you very much, sir. And you mentioned EBRT to the orbit. In patients who have EBRT to the orbit with implant extrusion, how do you tackle such situations? Do we reimplant, knowing that we've had some necrosis following EBRT, or how do we handle such situations?
We certainly plan for secondary implants, like Dr. Kans or something like we have seen before. If the biocompatible materials or these acrylic material or PMA cannot or silo cannot go in, by the time the tumor gets controlled and the patient has finished the external beam radiation, go for demi-spot graft. It helps.
Okay, thank you very much. So somebody wants to know where they can come for oculoplasty training in the country. They want to know if Ibadan or Kaduna or anywhere else in the country does oculoplasty fellowship training.
Well, there are many centers that have been accredited by the West African College of Surgeons, which has started fully the subspecialty training. Of course, the National Eyewear, Dr. Akam practice is there, usage is there, Ebonyi is there, Jos is there, so many centers. I'm sure they look at the website of West Africa College of Surgeons, they will see the accredited centers for oculoplasty in Nigeria.
Okay, thank you very much. I think that's about all the questions we have. Thankfully, we haven't overshot our time allocation too
There's
much.
one last question there that I'm seeing. So what
Okay,
prosthesis is the most? Somebody wants to be funny. I doff my hat for you, man.
Yes, I think that's all the questions we have. I want to thank you again, Dr. Fashina and Dr. Akang, for spending the last 1 hour, 25 minutes with us. And the Young Ophthalmologist Forum thanks you very much.
Cyril.
Yes, sir.
You made me to present 51 slides in 24 minutes. That is not fair.
Bravo. That means you are good.
That, you know, when the stuff is congenital, you actually don't need slides. You are able to distill as much as that within short time. It's congenital stuff, sir. So we thank you. We thank you. You and Dr. Fashino did a lot within a short period of time. You can see the Q&A took more time than even the presentation. So you see, when people like us that don't have stuff came to the equation, the time got extended. Thank you very much. I'm very grateful. We'll call on you, sir, once again in future. The oculoplasty series will run for the year, and we have about 3 more sessions for the year. Last year we had the in 2020 we had the cataract series. 2021 we had the glaucoma series, and we are hoping to have the vitreoretina and the oculoplasty series this year, if time and resources permit. Would likely call on users again this year to put us through again on some oculoplasty PLs. I want to thank you very much for joining us within this short time. Okay, sorry, we have one more question on YouTube. It just came in. Okay, no, it's a comment. The person says conjunctival conservation is very important and meticulous closure is very critical, from Dr. Bola Balogun. And also ring-like disinsertion of the sclera around the optic nerve is also helpful in preventing implant extrusion. Disinsertion of the sclera around the optic nerve prevents implant extrusion.
That's true. Talking about the conjunctiva,
Yes.
You must really preserve it. Don't go being adventurous, trying to trim everything, make it look so beautiful. I see some procedures that are done and then they will just drag the conjunctiva until you hardly find any space to put the conformer. That is criminal.
At times, you may even leave the conjunctiva. You can leave the conjunctiva when you have so much of tissue edema. You can leave the conjunctiva unsutured or tag it in 2 or 3 areas. Just leave it, but let the conformer be comfortably seated within that pocket.
Because you will need it. You will need the conjunctiva, every bit of it.
Thank you very much. Thank you very much. Thank you very much. So we've learned now that before doing an enucleation or evisceration, you should have conformers and have implants ready, because that gives better clinical outcome and better patient satisfaction. And these tools are readily available. We can call our colleagues to ask if they have any. If we don't have, and ask it be provided for our patients. Or if we can't have this provided for our patients, then we can refer to centers that have the tools to provide very good patient care, especially pre-op, intra-op, and post-op management. I want to thank you very much again. We can't thank you enough for giving us this last 90 minutes of your Sunday scheduled afternoon. And we appreciate your taking off time to be with us today. We thank you very much. Like I said, we most likely will call on you again before the end of the year to come give us some more pearls from oculoplasty. Thank you very much again, Drs. Akang and Dr. Fashino. The Young Ophthalmologist Forum thanks you very, very immensely. The chairman is here. Please, I would want the chairman to just say 1 or 2 words before we end the meeting. Dr. Ugochukwu, Chairman, Young Ophthalmologist Forum.
Wow. Thank you, moderator. I wish to thank our teachers, Dr. Fashino, Dr. Akan. Thank you for the wonderful lecture. You made this look more simple than it actually is, and we appreciate. We should thank every other person that participated in this webinar. Thank everybody. Thank you, Dr. Theory, for a wonderful moderation. We wish to meet us again during the next quarter. Thank you.
Thank you very much, everybody. Thank you for joining us. So we meet in next quarter, and then what Glaucoma Week is coming up in March. We're going to be having a lot of programs. We're also aware that most centers will also having programs. Please, let's try to showcase our programs as well as patient education for glaucoma. Glaucoma is still the silent thief of sight and is even worse among the Blacks. Thank you very much, and please have a nice week ahead.